Okay, we are back. This is House Healthcare with Chair Bill Lippert, Representative Bill Lippert, and Senate Health and Welfare, and I'm Senator Ginny Lyons. So we are back discussing provisions of Act 6 and then eventually Act 21 that we are under consideration for continuation or not. So we are on the third one down on page 2. Are we, Jen?
Yes, we just finished section 7. Now we're going into what was Act 91, section 8, and has been a number of other places since then.
Okay, take yours. It's all for
Great.
you. Yeah.
This section directs the Department of Financial Regulation to consider adopting and gives it the authority to adopt emergency rules for a couple of things. One is to expand health insurance coverage for and waive or limit cost sharing requirements directly related to COVID-19 diagnosis, treatment, and prevention. It also gives them the authority to adopt emergency rules to modify or suspend health insurance plan deductible requirements for all prescription drugs. And then there was a change in light of your committee's work on the audio only healthcare services, audio only telephone services, eliminated authority for DFR in that area, but added a requirement or provision giving them the authority to address health insurance coverage and reimbursement for telephone triage services. So this is a brief telephone call to determine whether an office visit of some sort is necessary. These provisions, this authority for DFR is currently in effect through March 31st of this year. The Provider Coalition recommended extending through March 31st of next year, although it was not clear to me whether that was for all of the provisions. I think they specifically called out the health insurance coverage and cost sharing requirements related to COVID diagnosis, treatment, and prevention.
This one has actually, from my understanding, has been very effective. The emergency rules were approved, a second iteration, I think, of emergency rules.
There have been a number of them.
Buying tests, right? And then there were the test purchasing, and then the diagnosis and treatment have all gone through LCAR, and I think they've been helpful. I know they've been helpful as compared with what's going on in other states. So this is one we'll have to hear from DFR and probably insurance folks. Any questions? Yes, Representative Black.
You actually caught it just at the end there. I'd really like to hear from the insurers about this. And I think there's also a lot of consumer confusion over what exactly is COVID related and what is not COVID related. So
Good
yeah,
question.
I would just like to get the insurers' perspective on this.
And if I might add that I think later on there's a reference, but it also might be useful to hear from pharmacists, because I think there's been some confusion. Well, maybe it comes up in the later part. Yes, actually, I'm referring to something else where the 90-day versus 30-day prescriptions.
Oh, hold that thought. Right. Yep. Yeah. Senator Cummings.
Yeah, I'd like to hear from the insurers. We're covering an awful lot of stuff, but eventually that's got to get paid for. And I'd like to know what kind of impact on rates. And also, what are we covering for treatment? Are we covering medication designed for farm animals under this?
Well,
I can be more
able
specific.
to ask that question, Senator.
Oh, that are being used for humans?
Yeah.
Yeah. Well, let's not go down that road right now.
I know. I mean, what are we covering? How far afield?
Yes.
Yeah.
That'll be that, and that'll be a good conversation. I know DFR has worked very hard on this with the insurers, so those are the folks who need to come in and help us understand what's happened.
I'm not clear if this is all being paid for with federal funds, if there's state funds, or if eventually the chickens are going to come home to roost on rates.
Right, exactly.
Okay.
Okay. And then the audio stuff, can we hold that till we get to the telemedicine section, or do we want to talk about that?
And I think there was some sense that that was going to be handled outside of this
Yeah,
flexibility bill.
yeah. Okay.
Madam Chair,
Oh, go ahead, Ruth.
I had my hand up, so I know it's hard to see everybody. What Representative Lippert just said maybe answers my question, but I did want to make sure that the audio only stuff we're handling separately in a different conversation. That's not part of this flexibility bill, is that?
That's right.
Correct.
Well, here's the issue. It may well be integrated into a single bill. However, the conversation is separate. And that's why one of the reasons we separated it on the agenda. And then there's the whole report that needs to be looked at and discussed. So yes, it will be separate, whether it's in one bill or two bills or however it goes across. Ultimately, that's also to be decided.
Okay, I just want to make sure we have a full conversation about that because I have questions and concerns. And I see that Jen does have a bullet point about it. And so that address health insurance coverage of and reimbursement for telephone triage services. Is that something different, Jen? Did I just miss that?
That's sort of a subset
Subset.
of audio only that was not included in the coverage provisions. The insurance. So last year you had done the whole insurance coverage requirement for audio only telephone services. Those had to be covered to the same extent that they would be if the service was delivered in person or through telemedicine. But that did not include telephone triage services. So when you had taken out this DFR emergency rulemaking authority around audio only telephone and brief telecommunication services, that was a piece that was identified as no longer covered, no longer being addressed. So that was added to give DFR emergency rulemaking authority for that narrow universe of audio only that wasn't otherwise included in what you had done on audio only.
Okay.
For the most part, the rest of what you did on audio only, you set up to run for a few years and check back in on what's happened with it. So you're not getting, so the reports aren't coming in now on audio only. The coverage requirement there was on or before January 1st, I believe, outside of the DFR rulemaking context. And so you had set 2022, the 2022 plan year for gathering data on utilization and outcomes and patient satisfaction, quality of care, things like that, with the requirement to come back in December of 2023 with a report on that.
Okay.
So I just want to make sure we're not conflating telemedicine or telehealth is such a large umbrella that we're not conflating the work you've done on telemedicine or on the interstate healthcare professionals providing telehealth with what you've also set up in the insurance area around audio only.
And it's the audio only stuff that we will really look at separately.
Great. Okay. Thank you,
Um,
Madam Chair, and thank you, Jen.
Okay, Representative Houghton.
That's okay, I'll pass. Thank you.
Okay. Anybody else? Because I really, Representative Lippert and I can only see so many of us. So thanks for speaking up.
And I'll just say that I think it is somewhat confusing as to which pieces are which in this area. And so
Yeah,
we will work to get clarity, but I think and particularly around the audio only, I think as Senator Hardy has asked that there will be opportunity for a separate and robust discussion about that.
okay. Next one, I think.
Okay. The next one requires health insurance plans and Medicaid to allow their members to refill prescriptions for chronic maintenance medications early so that they can keep a 30-day supply of each medication at home. This is currently in effect through March 31st of this year. OPR and the Provider Coalition both recommended extending this through March 31st of next year.
So Representative Lippert, you wanted to hear from the pharmacists on this one?
Well, yeah, yes, and is this, I don't have my own screen open, so I can't see, but wasn't there some reference at one point to something about 90-day refills as well, which I think is a separate provision perhaps. So
Yeah, I think it was the insurers who sent us a concern about this.
yeah, I think we just need to hear from, I think, without getting too lost in this, I know that there clearly was confusion early on, and maybe there still is at the pharmacy level as to what they're authorized to do and not do.
And it sounds like the insurance companies need to be involved in the
Perhaps, yeah.
testimony. Okay. Representative Cordes?
I think it might also be useful to get testimony from the committees of Vermont elders and the disabilities community to learn whether or not this 30 to 90-day extension in general, not just related to COVID, was beneficial, and to to folks that have transportation issues and live far away and maybe don't have access to the mail order pharmacy.
Good point. Okay. Any other comments on that section or questions? All right.
The next one allows pharmacists or allowed pharmacists to extend a previous prescription for a maintenance medication if the patient didn't have any refills left, or if the refill authorization recently expired and it was not feasible to get a new prescription or more refills from the prescriber. The pharmacist was required to notify the prescriber of any such extension in a timely manner. This was in effect through June 30th of 2021, and you did not extend this last year, nor has there been a recommendation or request to extend.
Yeah, and it may well be that as we hear testimony from some of the groups that Representative Cordes mentioned, the disabilities and elders, and there may be some discussion on that, but we haven't heard anything on that.
Consistent about things that have expired.
That was 21.
Yes.
So, okay.
Okay, and the next section has also expired. This one allowed pharmacists with a patient's informed consent to substitute an available prescription drug for something that is unavailable in the same therapeutic class if the available drug would have a substantially equivalent therapeutic effect, even though it is not officially a therapeutic equivalent drug. In this case, also the pharmacist would need to notify the prescriber of the actual drug, the dose, and the quantity dispensed. And this was another one that has expired and was not requested for extension.
Okay. Again, the pharmacist may want to comment on that. I guess my question is, with all of the supply chain issues that we've seen, are we seeing any pharmaceutical drug supply chain issues? I haven't heard of those yet, but we don't know. Okay. Any other questions on that? Okay.
The next one allows a healthcare professional to authorize renewal of an existing buprenorphine prescription without requiring an office visit. This is in effect through March 31st of this year. The Provider Coalition recommends extending it through March 31st of next year. And I believe they also recommended exploring, not necessarily in this bill, but exploring whether this was something to do, make permanent.
I actually worked with Katie McClinn last year to try to sort this one out a little bit to see what we could do. And I may go back and talk with her again. There might be a proposal that we can put in place as we look at, when it's our time to look at this bill. So that's just a heads up, not a big deal right now. Representative Black.
Thank you, Madam Chair. This one sort of always makes me feel a little icky. We're 2 years into this at this point. This sort of allows the prescribing of bupe without a visit for 2 years. I mean, can we somehow tie this to telehealth? Where you don't have to have a in-person visit and that it can be done via telehealth. I mean, it just feels like we did this because we were in the midst of a pandemic that we had no idea what we were doing or how to deal with these things, and it was put in place, but we kind of know what we're doing at this point.
So let's, I think that you're going to have to hear testimony on this, but also remember that your Human Services Committee, I think, was involved in the decision-making around this on buprenorphine, and that the federal government has also given some guidelines on reducing regulation around prescription for buprenorphine, or changing who does it. So there's more there than meets the eye. So testimony would, I think, help, and then communication back and forth with your other Human Services Committee, because no one wants to see someone who is under a substance use has a substance use disorder being left out in the cold and needing to be in contact with a provider. I don't think that's the point. I think it was you're right, it was an emergency decision. But
I'd just definitely like to hear some more testimony on this.
yeah, I think that's a good point. So Jessa, did you want to weigh in on clarifying this section? And then I think Representative Goldman has her hand up. Go ahead, Jessa.
Sure. I just wanted to clarify that the intent of this section, I think, is to get at exactly what Representative Black was suggesting, which is it allows the use of telehealth rather than an in-person office visit. So while the language just says office visit, it was because it had been restricted to an in-person office visit. So this is allowing the current renewal via telehealth, which otherwise would not be allowed. But if there's other clarifying language that would help with that, we'd be open to that.
Representative Goldman.
Thank you, Madam Chair. Yeah, I would be much more comfortable. I agree with Representative Black. There's, I don't know what the standard of care is for prescribing buprenorphine. So I wouldn't want to imply that we are creating medical standards. So I would want to know what those standards are. But if adding the telehealth piece is comforting to me. So as long as there's interaction between the patient and the medical system and it's done with standard of care, then I'm okay with that.
And let me weigh in and say, one of the reasons that we don't have all the information is that the testimony has been taken in the House Human Services Committee, which has substance use disorders in their jurisdiction, and they have actually had a great deal of testimony over the years around buprenorphine prescribing. So I'm going to suggest that while we have questions, that we raise them with them and that we defer to their. I've spoken with Representative Pugh and said that there were certain particular sections of Act 6 that they would need to weigh in on, and so I'm hoping that Jen, as we go through this, we can note specifically which sections should be referred for consideration by Human Services, and she indicated a willingness to do that in an expedited manner so that the bill can continue to move.
Terrific. And and as you know, our committee has
Right,
worked
and your
on
committee
this.
has joint,
Yeah,
has
so
full
when
jurisdiction.
we can funnel that into us, that'll be helpful.
Yep.
Okay, anything else on that one? All right, Jen.
Okay, and I do think it will be important on this one and perhaps on others as well, when people were talking about telehealth, to be clear whether you really mean the telemedicine live audio video connection or whether you're including audio only under that umbrella. So for drafting purposes, we can be specific. The next
wanna
one,
speak?
next. Sorry?
Did somebody have a question? Okay,
Sorry, mutitis. I was just wondering if you wanted comments on that now or later? Or whether
I don't-
audio,
let's do it later.
okay,
You write your comment down, and so then when discussion comes up in committee, you've got it ready to go. Yes, Representative Peterson.
Yes, Chair. I was wondering, Jen, are you writing in the far right column, and I can't see the heading right now because I scrolled down, but any notes that, yeah, the recommendations, any notes that we want to take further testimony? I know just for me, it would help if those sections where we need further testimony was just put in there somewhere so we could, follow it along and pick it out. Just a suggestion that one
So,
guy. look at it.
yeah, I think that's a good suggestion. I think that your chair is going to have to be involved in making those decisions. And so as we go forward, I'm actually taking notes about who
Me too.
is important in that. And I think that Representative Lippert likewise, and Jen
Okay.
is going to be very helpful in that.
Yes, I'm taking notes and I can, fill that in later. I'm trying not to do too much typing while you're talking, mostly because I feel like it does not reflect well on my typing skills. All right, our next section is section 13 from Act 91, and that allows the Agency of Human Services to reimburse Medicaid-funded long-term care facilities and other programs that provide 24-hour-a-day services for their bed hold days. These are the days when somebody is absent from the facility and perhaps to receive medical attention and may not otherwise be paid. I'm just trying to check my notes here. And I'm sorry, the Provider Coalition did recommend extending this through March 31st, 2013 as well. And I think this was another area that they thought might be one to look at for a permanent change.
Representative Goldman.
Jen just said what I was going to say about making this permanent and just having that on the table. So thank you.
Okay.
And I think I recalled that from one of their notes, but I don't mean to mischaracterize their position if that's not accurate. Section 17 from Act 91, which has been amended in a few different acts. This relates to out-of-state healthcare professionals, and this is related to the Act 21 telehealth recommendations as well. Under the current provisions, it deems a healthcare professional who is licensed, certified, or registered to provide healthcare services in any other U.S. jurisdiction as being licensed, certified, or registered to provide healthcare services to patients in Vermont using telehealth or as part of the staff of a licensed facility. That was the original language. Act 6 added authorization to provide services as a volunteer member of the Medical Reserve Corps or as part of the staff of a federally qualified health center. And then I was reminded during the testimony on this last time that it was in a bill that was not in this committee, which is why I didn't draft it. And I had forgotten that it had happened, but Act 69, the OPR bill, also added people who are serving on the staff of an other healthcare facility as defined in, this is actually the CON statutes is the reference, but it's a much broader definition of facility beyond licensed facility. So it sweeps in things like home health services that otherwise were left out of all of the other descriptions. So it deems an out-of-state provider to be authorized to provide services here using telehealth as part of the staff of a licensed facility or other healthcare facility, or as a volunteer member of the Medical Reserve Corps, or on the staff of an FQHC. That's the current state of things. And it requires an out-of-state healthcare professional who plans to provide their services in Vermont as part of the Medical Reserve Corps or as part of the staff of a licensed facility, other healthcare facility, or FQHC, basically everything but the telehealth piece, to submit to the Board of Medical Practice or OPR their name, contact information, and where they will be practicing. Those provisions are, sorry?
No, go ahead.
Those provisions are in effect through March 31st of this year. And the OPR, both OPR and the Provider Coalition recommend adopting, as they had mentioned again this morning, the Act 21 telehealth recommendations that came out of that working group to extend the Medical Reserve Corps and facility staff provisions through March 31st, 2023. So extend those. And then the Provider Coalition also had something in their written material around clarifying that this has no impact on the federal temporary nurse aid waiver for skilled nursing facilities. And I would let them address what they are referring to there.
Okay. Questions? Okay, we're good.
Okay, so that is the out-of-state provider.
Yep.
Part. And then for the next section, section 18, allows a former healthcare professional who retired from practice in Vermont, and actually the way the language has been changed, who's gone into inactive status not more than 3 years ago, to provide healthcare services to patients in Vermont by telehealth or as part of the staff of a licensed facility after submitting to the Board of Medical Practice or OPR their name, contact information, and where they will be practicing. Act 6 added the provisions around being a volunteer member of the Medical Reserve Corps or working with an FQHC, and Act 69 added working on the staff of an other healthcare facility. And then it also, that was for the fairly recently retired or inactive Vermont licensed professionals. And then it also allowed OPR and the Board of Medical Practice to issue free temporary licenses to former healthcare professionals who retired or went inactive from practice in Vermont between 3 and 10 years ago. And that would allow OPR and the Board of Medical Practice to impose limitations on their scope of practice as appropriate. So it might allow them to do certain things, but not others. Those provisions on recent retirees or recently inactive professionals in Vermont are currently in effect through March 31st of this year. OPR and the Provider Coalition recommend extending that through March 31st of next year.
It's hopefully it's having its effect right now. Senator Hardy.
Thank you, Madam Chair. I don't see, Jessa is still here. I'm a little hesitant to open this can of worms, but I've heard from people, and I'm sure that others have heard from retirees who are trying to go back into whatever profession it is, in this case, as a healthcare professional, that are having problems because of their retirement funds or taxation issues. And so this might be something my other committee deals with, but Jess, I'm wondering if you've heard that from retired physicians or nurses or nurse practitioners or whomever going back in. We seem to have dealt with the licensure issue here and the scope of practice and all of that, but maybe not their issues that they may be having with getting penalized on their retirement or something. Do you know if that's become an issue?
This is Jessa with the Medical Society. That is the first time I have heard that question. It is a new one to me. I understand the issue. and why it could come up, but actually it has not been posed to me. I don't know if OPR or the Board of Medical Practice, as they are issuing these licenses, have gotten any questions or put any thought into that, but I apologize. I don't have further feedback on that one.
Yeah, well, I think it's a
That's
great,
good to know that you
Yeah.
haven't heard
no,
more on
it's
it.
good.
Maybe it hasn't been an issue, but I have heard from a couple of people, not specific to physicians, that this is an issue about going back to work after being retired and getting penalized on their retirement. So maybe it's
I
not.
think it might be a pension question. I've heard the same thing, Senator Hardy, and I'm not sure it relates directly to healthcare, but certainly have heard it in other places, like going back to substitute teach and things like that. So this would be a great topic for Finance Committee.
Sorry, Ann. I just felt like I should bring it up because I have heard it from people, but glad to know
Yeah.
that the Medical
Yeah.
Society and others have not heard this issue. So maybe it's not a problem for doctors. Yay.
I heard it was a more generalized going back to work and losing some of your income tied benefits, some health insurance benefits.
Or Social Security.
Yeah, Social
Pension, all
Security
that stuff.
does start to reduce it 19,000 or 19,900.
That's where I've heard it, but I
Yeah.
haven't heard it particular to healthcare professionals, but just generally.
Yes,
So
generally.
you are now charged with solving this problem.
Okay, we'll do our best. Thank you.
I don't think it's in finances purview, but we'll talk about it.
Okay, any other questions? All right, next.
Okay. Next, we have provision that allows, if the director of OPR or the executive director of the Board of Medical Practice finds that their boards cannot reasonably, safely, and expeditiously convene a quorum, it allows them to exercise the full powers and duties of their respective boards, including disciplinary authority. And it requires their records of any actions that they take under this authority to be posted on their respective websites. So for OPR, it's on the website of the regulatory board on whose behalf the director took action. And for the Board of Medical Practice, it's on the Board of Medical Practice website. This provision is effective through March 31st of this year, and OPR and the Provider Coalition recommend extending it for an additional year.
Okay. Questions?
No.
We've heard that this is helpful, so
Yep.
that's up for deliberation. Go ahead, Jen, keep going.
Similarly, the next section, section 21 from Act 91, allows the director of OPR and the commissioner of health to issue orders governing regulatory professional activities and practices as needed to protect the public health, safety, and welfare. This one is also in effect through March 31st of this year, and OPR and the Provider Coalition recommend extending it through March 31st, 2023.
Questions?
I would just say that, I'm not questioning it, but it's pretty broad authority, and it might be useful at some point to hear some examples of if it's been used and how.
And I do think you've heard from Lauren Hibbert in the past, some of the things that she has.
I was
some of
thinking
the
more of the
issues.
Commissioner of Health. I'm sorry. Yes.
Okay.
I'm not questioning it, but just in being able to explain it.
Okay, the next section from Act 91, Section 22, says that it is not to be considered the emergency involuntary procedure of seclusion for a voluntary patient or for an involuntary patient in the care and custody of the Commissioner of Mental Health to be placed in quarantine if the patient has been exposed to COVID-19 or in isolation if the patient has tested positive for COVID-19. Similarly, it is not to be considered seclusion for a child in a residential treatment facility to be placed in quarantine if the child has been exposed to COVID-19 or in isolation if the child has tested positive There is no specific duration on this one, but it is tied to the COVID-19 exposure or positive test. So in that sense, it is by its own terms sort of limited to the context of the COVID state of emergency or COVID pandemic, not the state of emergency.
You know, it might be helpful to have a discussion, a committee discussion, as you or we go through this bill, this stuff, about reportable diseases generally, communicable diseases generally, and whether or not this serves a purpose beyond COVID. So just a thought. And I
Whether
don't
this
know
particular
what is,
provision.
yeah, I don't know whether that's currently in, I don't know whether COVID was an add-on or whether that's currently in statute for the Department of Health, so. No,
But I mean, there's a lot in statute around communicable diseases, but I
Right.
believe this idea of specifying that quarantine and isolation is not seclusion. The emergency involuntary procedure of seclusion is unique to this bill or this act.
okay, well, it's worth a conversation, I would think.
The next section allows the waiver of telehealth requirements relating to using HIPAA compliant connections if it is not practicable to use such a connection under the circumstances. And that is also tied to the federal government allowing that, because that's the genesis of this provision. And then sort of carved out from that is until 60 days following a declared state of emergency in Vermont as a result of COVID-19 allows waiver of informed consent requirements if it is not practicable to obtain or document informed consent under the circumstances. This is currently in effect for the waiver of the telehealth requirements related to the HIPAA compliant connection through March 31st of 2022, and the Provider Coalition recommends extending that through March 31st, 2023. The informed consent piece kind of goes along with the declared state of emergency, so it doesn't have a specific time provision.
It would be interesting to know where the glitches are in terms of HIPAA compliant connections. And so that's a question. I don't know who we ask, of whom we ask that question. So, but maybe the Alliance can help us. Senator Hardy, you have a question.
Yeah, on both of these provisions, my understanding for the HIPAA compliant connection is that was a big issue at the beginning of the pandemic when nobody was used to doing what we're doing right now, but that a lot of providers, Zoom and other providers, have created HIPAA compliant. I'm wondering if that is still a big issue, sort of like
Right.
what you said. And then I ironically, my internet connection is unstable. Can you hear me?
Yes, you went out a second,
Okay.
but you're back. You're fine.
We're just
Okay,
trying to work
excellent.
on compliant connections. Not as a HIPAA.
Forget it, yeah.
Yeah, exactly. Clearly the internet lords are punishing me for bringing that up. But the other one was the informed consent. Is that, Jen, now expired or not an issue because it's tied to the state of emergency?
Yes, this is something that you added last year in Act 6. And so until then, all three of the provisions around, well, for our purposes here, both of the provisions around waiver of telehealth requirements, the HIPAA compliant connection piece and the waiver of informed consent were all together. Last year, you separated out the informed consent to really tie it more closely to us being in a state of emergency. And so since we are more than 60 days out from the end of a declared state of emergency for COVID, that provision is not currently in effect, but it would get triggered again if we went back into a state of emergency.
Okay. Okay, good, because I think that's another one where people have learned how to work around it and get informed consent, and it seems an important thing to have. So,
Right.
thanks.
And I believe that was the
see Jessica.
concern raised by particularly Representative Donahue, who had proposed this change.
Yeah, absolutely. It looks like Jessa has her hand up.
Go ahead, Jessa.
Thank you, Jessa, with the Vermont Medical Society. I just want to clarify and agree with Senator Hardy. We are comfortable with that consent piece moving forward. We think there has been time to come into compliance with that. I think generally you're also correct that most providers have transitioned to compliant platforms as well. The real piece, and this is the piece I wanted to clarify, is what we're really looking for is not a blanket extension through March 31st, 2023, but that it be consistent or up until that time if the federal public health emergency allows, because HIPAA is a federal law and the federal government has allowed temporary waiver of using a compliant platform. We really just wanted to set up that it could continue until that point if the federal flexibility continues, so that they are consistent, but not necessarily saying that until March 31st, everyone will, not be using a HIPAA compliant platform, if that's a helpful clarification.
And this is kind of a shorthand, what we're looking at on this chart, the summary is a shorthand, but the way the language is in the acts themselves do what Jessa is describing. It says, here's these waivers are in effect to the extent they're permitted by federal law. So if the federal government stops waiving enforcement of the HIPAA compliant connection requirement, then the authority would go away in Vermont as well.
Okay, that makes me feel better. Thank you.
Representative Peterson.
Yes, thank you. I want to understand this particular one. So what does it really mean in practice? Informed consent is someone consenting to telehealth services. Is that what we're talking about? Okay, I see Jen shaking her head. Yes. And the waiver of the telehealth requirement relating to HIPAA, what does that part mean? Just trying to understand it.
Under federal law, there's a requirement that telemedicine happen using a HIPAA compliant audio video connection. And so in general, that is the way telemedicine has been done for a long time.
Perhaps saying something about what HIPAA is might be helpful, just in terms of the understanding of this.
Yeah, I just looked it up to understand a little, but any help is greatly
The name
appreciated.
tells you nothing about what we're talking about. The name is the Health Insurance Portability and Accountability Act of 1996. But what we mainly know HIPAA for is privacy, is healthcare privacy.
Okay.
And so this is making sure that it's a secure line that this telemedicine visit is happening over. That's the purpose of having the HIPAA compliant connection. But a lot of especially at the beginning of the pandemic, a lot of the platforms that were being used, like the kind of Zoom that we are on, is not a HIPAA compliant connection. And in recognition of that, with a lot of people turning to telemedicine and using telemedicine for the first time, a lot of providers using it who may not have been set up to do it previously, the federal government waived enforcement of that HIPAA compliant connection requirement. And I believe it is still being waived as we continue through this pandemic. So Vermont's authority to waive it is we only have that authority to the extent that the federal government is allowing that waiver. Because it's a federal requirement, Vermont couldn't say, well, we know the feds have the requirement, but we're saying you don't have to do it. We are saying, though, that we're waiving the Vermont requirement as long as the federal government is waiving the federal requirement.
Okay, thank you very much. Appreciate that.
Okay. Any other questions on that section? All right, Jen.
Okay, the next one is from this one was enacted in Act 140 of 2020, and this allowed a board or profession attached to OPR to issue a temporary license to a graduate of an approved education program if the licensing exam that is required for that profession was not reasonably available. This provision has expired. It was valid through last March, and there has not been a recommendation to reinstate it.
Okay. If there are questions, just speak up.
Cheryl Hooker. Thank you. Do we have any indication as to whether or not these exams are accessible now? I know there was a problem before of students being able to access them. Do we have any updated information on that? And is that something that we need to get before we?
I think, or I actually think OPR, Lauren Hibbert, did say something about that when she was in
Yes.
committee.
And she's
There
still
she
on.
is.
She is.
Hi, Madam Chair. We did see large disruptions to exams during the COVID state of emergency, and the exam providers, for the most part, have adapted very well to the current, restrictions on number of people in the building and masking, and we're not seeing that large disruption to exam services right now.
Is this something then that you would recommend continuing?
No, I don't recommend continuing this in Act 6. It's now part of the permanent law. So if we go back into a state of emergency at any time for COVID, the next pandemic, or, a large flood or something like that, we would have the authority to issue temporary licenses to people who can't take the exam. But I don't think we need this provision right now.
Thank you. Okay. Next one, Jen.
Yes, put my back up. All right, so the next one is authority for the Board of Medical Practice or its executive director to issue to an individual who is licensed as a physician, physician assistant, or podiatrist in another jurisdiction, a temporary license to practice in Vermont until not later than April 1st, and allows the board or its executive director to waive certain requirements, including scope of practice requirements for physician assistants, and may impose limitations or conditions on the license when granting the waiver, This provision is in effect through March 31st of this year. The Provider Coalition recommends extending it through March 31st of next year.
We didn't hear anything differently from David Hurley when he was in.
Yes, I don't know that he took a position on this. He
No.
did express the board's opposition to provisional licenses, but I don't think that's the
Right.
same.
Okay.
All right. Last two. The next one is the sunset on pharmacists' authority to order or administer COVID tests under a state protocol approved by the Commissioner of Health. So this is something that is currently allowed and is allowed until March 31st, 2022. This year, OPR and the Provider Coalition recommend extending this through March 31st of 2023. And then finally, there is the authorization for remote witnesses and explainers for advanced directives. This was an issue that was taken up in the House Human Services Committee initially. And this authorization lasts currently through June 30th, 2022. The Provider Coalition is recommending extending it through March 31st, 2023. And I believe this was another area that they flagged as one to potentially explore for permanent changes.
It's a permanent change.
Yeah. So I'm wondering, I thought our committee put it in and then sent it over, but it doesn't matter. It's there. The question is, should it become a permanent part of that process? And that's something I think that our committees can look at.
Right, and it's in terms of our process, it would seem to me that we could in fact make extensions even for things which we might want to make permanent.
Yes.
While we separately have a deliberation about which ones, and there's certain ones as like in terms of the pharmacist being able to order and provide COVID tests. It's like, why would we ever have a sunset on that at this point? It seems to me that's just my own first, if I'm understanding it. But But in order to continue our moving this bill forward and get it through, I might suggest that we, unless there's things that are obvious, that we not slow ourselves down by taking the additional deliberation of permanent.
No, that's the
Permanent
longer term
versus
discussion.
extension.
There might be some things that naturally fall out and everyone is agreeable to, so
I
then do it. But otherwise, let's not prolong our agony. I think working on this as quickly as possible is important.
Now, there is one issue, Senator Lyons, that came to my attention through an email, and I think probably others, but I hadn't seen it until it was brought to my attention another way, that the Office of the Healthcare Advocate, going back to the Green Mountain Care Board piece, has asked to be able to weigh in on the issue of the workforce piece, where we'd asked.
Yeah, I guess we just got sent that email while we were in committee. It didn't, so that's, we're gonna have to take that up separately, but as one of the witnesses going through Act 6.
I just wanted to make sure that we.
Yeah, I got
acknowledge
the
it.
same, I got the same message.
And I told Claire to post it to our webpage so that other.
Oh,
in the
okay, I
event
haven't
that not
gotten that
every-
far yet. I just said I'd look at it later.
Well, you've been busy walking us through the grid, so I had
All right.
a little more flexibility.
Yeah, I know. It does take time, doesn't it? Okay, so here's my suggestion, folks. First, Representative Goldman has a question.
Well, you might answer my question. I'm just trying to understand time frame because it is very close. And we do want to get it done. So, with BAA, we had to have it done by Tuesday, and that was really helpful. It really made us do the work. So if we could have like a timeline, that would be fantastic.
We'll give you one. Representative Lippert and I are working on that, and we're trying to be as efficient as possible. So we will get there. Representative Peterson. Page. Sorry.
I don't know how you could confuse the two of us, but,
Sorry.
but I just have
the vest. It's the vest that confuses.
It is the vest. There it is.
Yes, thank you. I just have a question, and maybe it's all in this as well. With all of our telehealth communications and requirements, and I'm just curious, are there any protections built into this system for protection against cyber attacks and things of that nature? Or is that outside these particular acts?
So this is a really, really good question. And rather than have everyone here answer that question right now, it's probably something that you might want to take up in committee going forward. Yes, we never expected the hospital cyber attack in my hospital, but yet there it was, and it was not healthy. So good question. And how that was handled may actually inform information that would answer your question. So I'm going to suggest right now, unless there are questions about what we've just been through, we've got a better picture of where we are a little bit and who we need to hear from going forward. I'm going to suggest that we move on to Act 21 and 20 and 12. I'm going to suggest that we move on to Act 21 and telehealth, and that we have folks who are here ready to testify provide that testimony. So we have a list of people who have not yet testified, and I'm going to suggest that we start with Rebecca Copans of Blue Cross and Blue Shield, and then move through the rest of folks who are here, ending with probably Lauren Hibbert, who always seems to bring up she does the bottom line work for us. So thanks. Okay. Rebecca, thank you for being here.
Thank you, Senator Lyons. My name is Rebecca Copans, and I joined Blue Cross and Blue Shield at the beginning of the pandemic. And I wanted to just introduce myself. Many of you know me. But those of you who don't, I live in Montpelier with my husband, John, and our 3 children. The second of whom came to us through the foster care system as a teenager. And so the lens through which I see the world and view policy is from the perspective of a mother of someone who spent far too long navigating the foster care system, and also the daughter of someone who tends to have a knack for putting her trust in the hands of providers who don't always deserve it. That said, Blue Cross fully supports increasing Vermonters' access to healthcare and creating an avenue to care that balances flexibility and access with careful patient protections, which is our primary goal with this and all telehealth legislation. I want to give my sincere thanks to Lauren Hibbert and her staff at OPR for their process that allowed this issue to be looked at from every angle and that offered the opportunity for all of the stakeholders to weigh in on this issue. Universally, the group agreed that continuing to allow a full waiver of license to out-of-state providers does not offer the protections that Vermonters deserve. Mandating provider registration and creating a path for a streamlined, time-limited approach that supports access to and continuity of care, while ensuring that if a provider is practicing in Vermont over the long term, they pursue licensure, we feel is the best approach to balancing access and protection. The one place that Blue Cross diverged from the recommendation of the work group is whether providers should periodically have an in-person visit with their patients. We believe strongly in the considerable value of every patient having a trusted medical home, not only for the continuity of care, but for continuity of data that allows for care management, which improves a patient's quality outcomes. While Vermonters are seeking prolonged medical care via telehealth, we believe that there's incredible value in a provider to see them, hear them, and touch them at some regular interval, be it their primary care provider or a specialist. And after 2 years, nearly, in this remote world, we all acknowledge that an elemental component is missing without in-person interactions. Vermont should require that a patient be seen in person periodically by some type of provider when they're undergoing a course of medical treatment via telehealth. And that should be inclusive of both in-state and out-of-state care. And when you're considering this in all legislation, I urge you to consider patient protections over the long term and not simply through the lens of the shortages wrought by the pandemic. Overall, Blue Cross supports the expanded access to providers and the care that's the basis of these recommendations. Thank you for taking up this important issue and for serving our community with such obvious care.
Thank you. That was very helpful. We appreciate your comments very much. Representative Donahue.
Yes, thank you. We are in the middle of this process of interim and temporary and trying to keep people connected. And my understanding is that Blue Cross Blue Shield sort of unilaterally decided in September to discontinue any reimbursement for telehealth for mental health if the provider was out of network. Is that accurate?
We reimburse for in-network care. Mental health is reimbursed at the same rate as an in-person care. We made the change for out-of-network providers, and we really would encourage all providers to become an in-network provider with us.
So out-of-network providers were being reimbursed, maybe a lower rate or higher copay for a person, but they, as part of this interim response, they were being reimbursed, and then you changed that policy in September. Is that correct?
We no longer provide the same reimbursement for out-of-network providers.
Is it the same reimbursements or any? It's not covered at all anymore. That's my understanding. You disallowed it completely as a coverable care?
I'd have to get specifics, and I can follow up with you about it. But my understanding is that we offer the same coverage for in-network providers, but it's no longer the case for those who don't contract with us.
Okay, yeah, I think it'd be helpful to get clarification because it may be something we need to have a better understanding of what kind of limitations there are or aren't and how people are informed about those limitations rather than assuming an ongoing process and then retroactively discovering their care isn't covered.
That's a really good question. We've all heard concerns about this. So thank you for asking.
It's purely coincidental. I apologize for the surprise question, but I got an email about it about an hour ago from somebody who received care from September to December and then now has.
Well, it's now out on the
have coverage.
table and, you know, perhaps Blue Cross and Blue Shield can help us understand whether it's part of the Act 66 conversation or how it fits in. We'll see. Representative Houghton.
We'd be happy to follow up.
Thank you. Yeah, thanks a lot. Representative
Thank you.
Houghton.
I just want to add to what Representative Donahue said and make the request of Rebecca to further it, just not for what is for out of network, but I've also heard the same thing about speech language pathology services, occupational therapy, and physical therapy as well. So if there's changes within network of those, I'd like to have further clarification as well. Thank you.
Okay, I'll follow up with that.
Okay. And Lauren Hibbert is here, so you have maybe a little understanding of this at some point would be helpful.
We definitely have triaged some calls about this issue, but we have been directing people to the insurers to answer the questions. So I'm aware of the issue, but I don't have any answers to that.
Okay, and certainly DFR might be able to weigh in on this at some point. All right, which is not necessarily in legislation. I don't know what's happening. I think one of the things that needs to be determined is whether or not any decisions that are being made reflect statutory intent. I don't know whether this is guidance or rules or how the decisions are being made. I think, you know, sorting out where it fits within the whole insurance regulatory scheme is helpful. Okay.
If I may, I would just simply add, we've taken we put an enormous amount of attention on the pressures on our mental health services. And it's of particular concern where if decisions are being made that limit access to mental health providers in this particularly critical period of time. So
you know, that does raise a question, and this is for Blue Cross and Blue Shield. It does raise the question. We always look for parity for mental health and physical health. If we can separate those two, I'm not sure we actually can. So the question is, are there other conditions for which the same decision has been made? So it sounds like physical therapy and speech therapy might be also in that category. All right.
Let's come back to that.
We'll come back to that. That's kind of tangential, but not really. Okay. Thank you very much, Rebecca, and for being patient. And someday our committee, or at least I, would like to have the conversation about raising a foster child and your experience in the system. So let's move on to David. Is David Hurley? He's still here? He's not. I think he offered his comments earlier.
Yes, he offered comments on Act 21 and he had to leave earlier.
So let's move on to Devin and Jessa. I'm thinking that you two are a team yet again, and if you could help us with Act 21.
Sure, I'll start and then Jessica can jump in. I think we had testified earlier, we do support the recommendations under Act 21. I think our only concern is just making sure that there is no disconnect between implementation and the current flexibilities that we have now around telehealth.
So you're looking for a bridge that carries forward?
Yeah, and I think that is offered up by OPR in the report where they say for the next year, we will have this registration process, which we support. And so we would just want that to move forward expediently.
Okay.
And Jessa Barnard with the Medical Society. The only piece I want to address, because I think Rebecca did a great job bringing it up on behalf of Blue Cross, is the piece about an in-person requirement. The coalition did, or sorry, not coalition, the stakeholder group that OPR convened had a lot of discussion around this area. And I think where we landed and where the Medical Society would be supportive of is if there are to be any requirements in that direction, that any of that be considered at the profession level, because it really rather than in statute across the board, it looks so different in different situations. If you think these could be one-time urgent care consults where that provider is not available for an in-person visit, or this could be a 3-year-long mental health clinician relationship where maybe that does make sense. And we really think it should be up to the standard of care for that profession, whether that's a Vermont provider or out-of-state provider. It's about meeting the standard of care. And it also, if there are to be any, across the, general requirements, it should be specific to a profession rather than for all telehealth relationships, because what makes sense in one situation may not make sense in another. So I just wanted to offer that perspective. Otherwise, we support both what OPR and VOZ just said in terms of the framework moving forward. Thank you.
Okay, so then during that transition period where there's registration, there can be further discussion about professional standards and decision-making. That's helpful. Okay. Any questions then? Any questions for Representative Lippert?
Yes, I would welcome any comments with regard to, well, let me back up. We've talked, there are 2 tiers, as I remember, there's 2 tiers of recommendations for the, coming from the stakeholder group that OPR facilitated. And we talked initially of trying to include the tier 1 recommendations about registration in any legislation we move forward with Act 6. As I listened here today, I'm hearing that there's a rationale, and perhaps a compelling rationale, for including not just tier 1, but tier 2 in the legislation that we move forward, so that particularly the rulemaking process can get underway so that the implementation can be guaranteed more smoothly and in a timely manner. And so I think that recommendation, I just want to just ask any of the witnesses that are here and available today, whether what their view is about including tier 1 and 2 tier 1 and tier 2 in the package, if you will, of legislation that we would try to move forward in a fairly timely manner.
Let's let Lauren Hibbert have the last word on all of this. She's going to underscore the issues before us.
And to the degree others have not commented on that, I would
Sure,
welcome their comments as well.
Didn't mean to exclude anybody.
Sure.
Thank you. My concern about including tier 2 is that we do need fees attached to that long-term registration and long-term telehealth license. And I just want to emphasize the complexity. It's 63 different fees within OPR and at least 5 or 6 within the Board of Medical Practice, setting those fees. And you all know far better than I do the complexity of setting fees in statute. It adds a lot of committees. And so I think there's some simplicity on moving forward with the tier 1 recommendation, the short-term registration in the Act 6 extension, and simultaneously or concurrently moving forward the second tier recommendation of Act 21 with the goal of passing that by the end of this session. And that is a sincere and really urgent plea from me to move forward on the Act 21 recommendations this session. I just think it does make sense to bifurcate the short-term solution and put it into the Act 6 recommendations, understanding that we have made a general fund allocation request to support OPR's work on the short-term recommendations and ultimately probably on the long-term recommendations until that fee revenue comes in July of 2023. So that would be my ask. If you think legislatively that we could get through all of the set of recommendations by the time we need it for, the cliff that we're facing of March 30th, which I take very seriously. When I hear Devin talking about the urgency, I feel a very personal, like I can feel the weight on my shoulders of getting this done to make sure that it happens for the provider community. So I just want to make sure that we have a smooth transition plan for the people who are providing telehealth at the end of March, and that we have a path forward as we are leaving the session for the long-term telehealth solution.
Can I just respond and say that reminder is very helpful. I know when you brought that up previously, immediately it was the flag, and I was like, that's why we would not include tier 2. I might suggest that we have some consultation, particularly in the House, with the Ways and Means Committee about this, to both just touch base with them, alert them to this issue, and that we're actually, it's critical to move it forward within this session, nevertheless, even if it's a separate bill, but also to see if they have any creative solutions about how different parts could be bifurcated so that perhaps one part could move forward, the fees could be dealt with separately from the rulemaking that could be commenced, et cetera. But I'm going to suggest that we, at least on the House side, because the Ways and Means Committee is always involved in fees and it does require their jurisdiction, that we have some consultation there to help think about that.
And I would be happy.
But I hear the compelling reason for having it as two separate bills, even if they're passed, so that the one bill might make its way to Ways and Means and the other keeps moving.
Yes, and thank you for hearing that. And I'm happy to assist in the conversation with Ways and Means in any way that you would like me to participate.
Thank you.
Before I make my comment, Jessa or Devin, did you want to add? So just the good news is that we have the chair of finance with us. And so she is hearing the concern, and perhaps she and her committee member who is also here will be able to weigh in on this and help us out going forward. So, but do you want to say anything, Senator Cummings? No. Okay. But it is a conundrum, no question about it. And then but we all know this Act 6 needs to move quickly, and going through 20 different committees wouldn't help at this time. So we'll do what we can do. If there's a negotiated agreement that could be made, fine. If not, then it becomes definitely two bills. So it's just a matter of working together.
And I just, again, Lauren, you said it well, and others have, but I'll just say it again, that it's important for us to help our colleagues who are focusing on other issues right now to understand it's not just a deadline of March 31st. It's in anticipation of being able to project continuity to those providers and patients, those who are using services, because we've had many questions raised to us about, what am I going to anticipate? What do I have to? People are worrying about a change in policy that would disrupt their continuity of service.
Well said.
Good reason.
Go ahead.
For me, logistically, my deadline is February 15th, because 45 days out. I mean, I understand that I'm saying this on January 13th, and I fully recognize the pressure that I've just put on your shoulders, but, and I'm sorry for that, but projecting continuity and messaging is going to take time, and I'm going to need to have this registration set up by the end of February at the very latest, so that people can get processed through, so that they have I cannot say that word. I apologize. The continuation of continuity.
Continuity.
I'm dyslexic, so there's too many vowels in there for me. And I can say it after somebody else says it, but I cannot say it sua sponte, so I apologize. So you know, I just, for me, the urgency on Act 6 and the registration is so high that I worry about adding the fee complexity.
Can we be very clear with you, Lauren, or can we add even a more point of care? You're saying, I need to know this is in law. This means a signature by the governor by February 15th. Or passage by both bodies so that you can anticipate being able to move forward.
What I would love is a bill number first, so that I can direct people who are contacting me to follow the bill. And then, yes, steady
movement. Provide that shortly.
Okay, thank you. And then steady movement. I think if it's passed by one body, and this joint session gives me a lot of comfort and predictability. And I know this is going to be signed by the governor. I mean, I don't know. Nobody knows what the governor is going to sign, but I know that this would have the governor's support. So as soon as we have a bill number and these committees agree, then I can start working on creating the registration. But it would be really great for me to have something concrete to point people to as they're emailing me. And I know they're emailing you all as well. So
there will be a bill soon, and it will be in one of the two committees, and then it will move with alacrity.
Right. And we'll work with Jen Carby because committee bills sometimes don't have a number early on, but we'll work it. There's our ways to work this around. We can work around this. We've been here before.
I know, and I appreciate that, and I hope, and I apologize for my brashness and my urgency.
We're asking you to be very direct with us, and I think that's Representative Goldman earlier was also saying, look, tell us what you need, because that helps us to then respond, and we can respond when we need to know, when we know. So I appreciate that.
You aren't the only one who has told us that we need to work quickly. We get it. Thank you. Any other questions? So Representative Lippert and I are going to put our heads together so that we can move forward and put a plan in place. Whether we meet again as joint committees may not be right away. So one committee will be taking the lead on this, and then we will probably get together another time just to see what's happened, so that we can again understand decision making on the specific areas of the bill, and then the next committee will pick it up and run it right over the finish line. So quickly. I know it's football. Is that no?
It works.
Could be rugby. I don't know. Okay. So good. We should all work together and we'll make it happen. So I think unless there are other questions, I think we need a little bit of a break and some time. They'll give us 10 minutes extra. Oh, wait a minute. End zone, goal line. Oh. Got a home run. Oh, what else? An ace. We're going to hit an ace. That's what we're going to do. Okay. Tennis is my sport. All right.
Slam dunk.
Yep. All right. So we're good, everyone. Thank you all for being here. I'm going to just ask if Bill and Jen and Aaron, and Claire, if you could just stay around for just a quick minute for some scheduling questions.
Yep.
All right.
Great. Thank you all.
Thank you.
Okay. You didn't want us, right?
No.
Do you want to go off YouTube?
Oh,
yes,
please.